Yeah.
Okay. Okay. Welcome everybody to this webinar on remote consultations in mental health and about the innovations that we've seen in practice. My name is Fiona Gochran. I've been the SRO for this project, working very closely with a fantastic team from all the groups you'll see here, the 3 mental health trusts across South London, our wonderful Health Innovation Network, the Applied Research Collaboration and King's College London. And so it's been a great experience. We're hoping that we'll be able to share some interesting topics with this about this with you today. So just to make sure that you all know that the webinar is being recorded, we'd encourage you that there is a Q&A function at the bottom of your screen, and that's the best place to put in questions, and we'll try and address those as we go along after each of the speakers. So, and if you're able to, if there's some uncertainty, if you're able to make it clear to whom you want to direct that question, that'd be really useful. If you want to tweet, then the hashtag is up there on the screen. It's hashtag remote consultations, all one word. And the other thing I want to do is to thank the Q Foundation very much for funding this webinar and this series of webinars to be able to share our work with you. And we're very, very grateful to them for doing that, because the whole idea of this was to get information out into the public domain as quickly as we possibly could. So George, would you do let me know, by the way, I've had internet problems this morning. I've had to go onto my hotspot on my phone, so it may get iffy. So do let me know if in particular, if my sound isn't doing well, and somebody else may help me with the chairing. So just let me know in the chat if that's the case. We'll keep an eye on that. It is a possibility, and I apologize. Until about 10 to 1, sound was perfect. But then our system crashed, so it may not be good. But I'm just going to give you a quick overview. As I say, in my day job, I am lead consultant psychiatrist in the National Psychosis Unit. I'm director of research and development in South London and Maudsley, and I'm also professor of physical health and clinical therapeutics in psychiatry in the Institute of Psychiatry in King's. Next slide, please. So this all started out, in the first rush of the first wave of the pandemic, when it was apparent that we had all had to make major changes really, really quickly to minimize face-to-face contact, minimize infection transmission, and utilize whatever we could in terms of the remote infrastructures that were available to us, and all that entailed, both technologically and interpersonally. The idea, and we suddenly went, well, lots of people doing lots of different evaluations. So but it would be great if these were comparable, and also how do we bring all these together as quickly as possible, and sort of to create a sort of action research or learning healthcare system. So gathering information, pulling it together, making some sense of it, and hopefully communicating it to others like yourselves in a rolling way, and hearing back from you as well. So your voices will be really important here. What was key about this project is we had really, really strong and excellent expert by experience voice. So this was really informed to do that, and they were recruited specifically for the project. And without them, we would, they were key to our direction, really, in keeping us on track. In terms of accountability, we're accountable to the 3 mental health trusts via a core group of senior leadership representatives, all of whom were part of the team. And the idea was to understand the impact of remote mental health usage, care provision, and appointments. George, would you mind giving me the next slide, please? So as I mentioned, this is a very large partnership, but it's been great. We've had great attendance and great input. I mentioned the people involved this earlier, including King's Improvement Science, who are part of KCL. And then we had this wider stakeholder group reported to South East and South West London CCGs, the Quality Centre in SLAM, which is where we take our clinical academic groups, go to sort of try and accelerate evidence into practice, King's Health Partners, and the NIHR's, the other London NIHR applied research collaborations, both in North Thames and North West London. The other London AHSNs, the NHS Confederation, NHS E&I, and the mental health, regional national mental health networks, and also the London Evaluation Cell of NHS E&I, voluntary sector providers, and of course those experts by experience who are key. Next slide, please. So this is what we did. We tried to just kind of have a look and see what's known already, what are we finding out right now, and what are we going to know in the future. So workstream 1, and sorry, I'm not going to start with workstream 3 actually, because that's what we know already. So those were the 2 evidence reviews, which was what's called an umbrella review. It's a systematic review of systematic reviews. So we took all those reviews that have been done of remote working in mental health services, and that was a lot, over 1,000 citations, and we ended up with 27 eligible papers on that, and that's summarised in the resources. So that's what was known already. That's all sort of quite cold, planned evaluations, not in a rush, and pooled together the information, the knowledge and learning from those systematic reviews. And then we've just had a paper published on the review of remote consultations that took place during COVID. Very different environment. Your alternatives to remote care were very different during COVID, and things that happened very quickly. So we found 77 relevant papers there. And on the web link that you'll have, there's a triangulation report of the findings from these and the other 2 work streams. Workstream 2 was, you'll hear a little bit about as we go through, but that was a review of all the patients and staff surveys that took place in South London and Maudsley, Southwest London and St George's, and Oxley's NHS Trust. And we had a total of 6,000 patients and 700 staff responses across the full range of services there. And the idea is with that we wanted to sort of bring that together, learn from each other's findings, and sharing data, and try and move towards future inquiries being comparable as well. And then the third thing we did was our group led by Lucy Goulding tried to capture and map, using a survey, the various different evaluations of remote working that were kind of taking place last summer. So some of these will be going through the system and hopefully soon to report, but to know what questions have been asked, and also so that we know where the gaps are, what we need to ask in the future. So the idea was that we would bring together the evidence that's existing, pool and make comparable the evidence that we're collecting, and have an idea to what's being collected in the future and where the gaps there might be. And as I say, that's all pulled together in our triangulation report, which is summarised on the resources page in the HIN. Next slide, please, George. So the next thing I need to do now, that's the sort of introductory thing. And I want to now ask my colleague, Eva Salm in SLAM, who's the Deputy Director of Informatics in SLAM. And she's going to talk to us about one of the innovations that took place in SLAM, and about the Staying Connected dashboard. So Eva, would you be able to?
Absolutely. So we at SLAM created a Staying Connected dashboard. George, if you can move to the next slide. So this was in response to COVID, and we wanted to ensure that we were staying connected with all our patients and keeping in regular contact with them, but also to see the types of contact that we were having with those patients. And then once we had access to the shielding list from the government, we added an additional report in to make sure we could identify the patients that we had that were meant to be shielding, and check to make sure that they weren't being digitally excluded. Next slide, please. So this is what our dashboard looks like. This is one of the pages on it. So this shows activity over time, and you can see that as COVID came in, we had a massive shift away from face-to-face into video contacts, telephone contacts. And over time, that's face-to-face has slowly been increasing back up, and it's getting back to about 50%. Interestingly enough, in there, it's our videos that are decreasing of the telephone contacts, percentage-wise. What we've also found is that we have also put filters on this, which means that we can have a look at different types of services, age groups, ethnicity, and see the different types of contacts that those people prefer. So, for example, CAMS, you can see much higher proportion of people using video contacts. And over in our older adult services, it's a lot higher on telephone and face-to-face, with very few video contacts being made. So it's been fascinating to be able to actually evaluate different services and see what's happening, so that we can provide the right services to those patients or contacts. Next slide, please. So this is by consultation type, and it also gives us our diagnostic chapter in there. So with this, we can see whether we have different types of contacts for different diagnoses. You might have people that maybe prefer not to use video or face-to-face. It allows us to also look at the DNA rate for those different types of contacts. So for telephone contacts, we have about, I think it works out at about a 1/7. No, wrong one. But one of them is around 1/4 of our contacts are actually with DNA on certain types of mediums, so it allows us to see what's more effective, what isn't. And we can also cross-filter on there for gender, ethnicity, and things like that. So it allows us to keep track and see what's happening with that over time. Next slide, please. So this one is our current caseloads. This refreshes regularly and allows individual teams to look at their caseloads. Have they got any patients who haven't been contacted recently? We do have some patients that look like they haven't been contacted, but it's the way it's recorded in the system. And again, you can cross-filter on all that, filter down to team or specific types of services to see what the difference in trends are with that. Interestingly, we find that patients with schizophrenia tend to prefer, I think it was in person and telephone over video. But it's again, just allows us to have a look and see what our current caseload is doing as well, and the proportions for that. And allows the teams to keep in contact with their patients as well. So if we can move to the next slide. So this is our digitally excluded patients. So it looks at each individual patient, whether they're on the shielding list or not, and the type of contacts that they've had. So we can then filter that right down to look at someone, for example, who's had no phone or video contact, but is being contacted by face-to-face, but is on the shielding list. And then what can we do to help actually protect those people? And potentially provide them with devices to allow them to keep in contact with us in a safer manner. So that's our dashboard. So quick presentation, I know, but we can move on to questions.
Thank you very much, Eva. That's fantastic and really, really interesting. We've had, just to remind people to put questions in the Q&A box, but I have a couple of other questions as well. Do you consider, somebody's asked about what we think about the low use of video by older adults. What do you think of that? Could you talk a bit more about your distribution of your uptake of remote options, Tom?
So that was when I was saying that, I was also using our dementia service, so it may just be a complexity factor. We haven't looked into that I haven't looked into that in any great detail as to why that might be the case, but potentially just the general distribution of how people are actually used to using technology or not. Okay,
very good. And Rowena Kelly has remarked that she works remotely with older adults and would say if there are other barriers such as language, culture, then they prefer to have face-to-face vaccine permitted. We've also been asked what was the criteria for digitally excluded and how did we gain the data for patients in that group, which of course is a big challenge.
Yeah, so what we were looking at is just the way, sort of our solution to it was to look at whether they had contacts that were by phone or video. If they had, then we made the assumption that they had some form of digital device in which they could contact us with, or we could contact them. And that's just the way we looked at it. It was the simplest way of looking at it at the time when we were building this.
Okay, very good. Thank you very much. Durek is asking, mental health seems to be in the top 3 specialties making use of video in London. Do you have any thoughts on why that might be, considering other non-invasive specialties are not such high users?
I think it's probably to do with the sort of care that we provide. I think we keep in much more regular contact with our patients than potentially other services do. Whereas our physical health services probably were more diverted into supporting COVID at the time. They could potentially slow their services down. We need to support our communities. So we had to adapt a lot more quickly to these types of technologies to be able to continue to support the patients we had in a safe manner.
Really helpful. And we've probably time for 1 to 2 more questions, but just Alan has mentioned carers are an important component of the therapeutic process. Very true. Were we able to gather any data for the dashboard with from carers for this exercise or not?
So we didn't look at carers in this exercise to the way that their information is recorded in the system. But potentially that is something that should be looked at as well, definitely.
That's really helpful. And somebody else has mentioned that we can't, about hybrid approaches to patients, and how seeing people not 100% remotely. Were we able to pick up where there was a mixture of approaches used?
Yes, absolutely. So I think if on the digitally excluded slide, you can see that we've actually looked across that and see what types of mediums they've had. So you can do that as well, and we haven't that information, so we can look at that hybrid. What we haven't done is looked at the difference between, say, first contact versus later contact, or assessments versus treatments. But we have looked at sort of, are we getting a range across people, which we actually are.
Brilliant. Eva, that was really fantastic. Thank you very much. And really nice to see that summarized so well. Thank you. And we really appreciate you coming along. And there might be some questions later on, so we'll look forward to having your input. And I'm going to move on now to the next presentation, which is from South West London and St. George's about their Recovery College. And here to tell us all about how they adapted to the new world we live in is Lindsay Fox, who is the communications coordinator at South West London and St. George's and at the Recovery College, and Andrea Lewis, who's the admin lead for the Recovery Colleges in South West London and St. George's. And welcome very much to Lindsay and Andrea. And I'm very much looking forward to hearing you tell us all about it. Thank you.
Thank you. I think it's important to give you a little bit of context about the Recovery College first. So we were the first to set up in the UK, and we are a non-clinical service. So essentially what we do is we provide courses that give our students knowledge, skills and tools that help them better manage their own mental health. And our student base, which is about 4,500 strong, primarily made up of secondary care patients or those who've been recently discharged. We also provide training for friends, family and carers, so the support structure for those individuals, for some of our staff, and also for some categories of primary care patients. And the model that we deliver, everything that we do is co-produced and co-delivered by a practitioner trainer who would likely be somebody with a background as an occupational therapist, a nurse or a social worker, and a peer trainer. And all of our peer trainers are individuals who have lived experience of mental health issues. So our service is quite complex, runs over about 5 boroughs, 36 courses. And back in 2020, like a lot of teams, we were faced with the proposition of, do we redeploy the entire team somewhere else, wherever we're needed because of the pandemic, or do we remodel the service? And what my colleague Andrea is going to go through is some of the things that we managed to deliver on the next slide. So George, if we could have that, please.
Hello, everybody. So we it was decided that we were going to go ahead and remodel the service. And there were two approaches that we took. One was we delivered and we introduced a phone line system, and the other was the webinars. The phone line systems was put into practice very quickly, and we needed to involve the IT department as well as the leads within the team. We had to prepare rotas to see that all our trainers were available, and we also had to download the systems so that they could work remotely on the phone lines. We were really excited. We went in, you know, all happy, and we're like, yes, we're going to receive all these phone calls, but it wasn't received very well. So we improvised. We went and we thought, what do we do better? So we contacted all the students on our database that were active just before we went into lockdown and 3 terms prior to that. So the trainers that were peer trainers and lead trainers used to call students just to check in and see how they were doing. And it was well received, and our students really appreciated the contact. They were happy that the Recovery College was still functional. And initially it was just call us if you want support. And afterwards, when we developed the e-learning hub, we had other support options that we could offer them online. The other thing that we developed and we're really proud of were our webinars. So that went into practice fairly quickly. Again, the webinars were delivered by trainers and peer trainers. So we had the mindfulness and relaxation webinars, which had 8 students on them, and the trainers, and our self-management webinars that had 6 students. It was important that we maintain the classroom setting, and we had students interact with each other and the trainers. Therefore, we didn't open it up to the wider public. We restricted numbers on the webinars. They were short and interactive, and this really boded well with the students. They enjoyed what they were seeing, and the content was adapted by the quality assurance panel, and we took into account the risk factors and how we put protocols in place to assist if there were any problems on the webinars.
And one of the final things that we did that took a little bit of time for us was to develop an online hub, which we've called the e-learning hub. It's something that we've always wanted to be able to do because we recognize people learn in different styles and at different paces. So what we've developed is an online library of a variety of formats. So we've got short videos that we've created on mindfulness exercises. There are audio tracks on relaxation techniques. We've got the usual blogs and newsletters, but we've also looked at all of our courses and broken them down into bite-sized course downloads. Some of them have got audio tracks over the top of them as well. Some of them have also got subtitles included where we were able to. But again, I think Andrea mentioned we've got a quality assurance panel. So they take a very close look at what we feel is appropriate for the channel that we're actually delivering in. So now what we've got is a service that allows our students to learn at their own pace and the ability to select content that matches how they learn and how they absorb information. So on the next slide, we're going to talk about a few of the challenges that we faced.
So one of the challenges we faced was IT infrastructure, because all of us moved into remote working very quickly. We needed to assimilate all the information for all the trainers as to where they were based, because they were all working from home. We had to get them laptops, set up the software on their system. Now, most of our trainers are clinically vulnerable, and some of them were even shielding. So it required logistics where IT had to assemble the entire unit and leave it outside their house so they could just connect it and, start off. However, there were still problems, and that's when Lindsay, the manager, or I stepped in to assist them with it.
One of the challenges, obviously, I think I referred to earlier, is the nature of the course content. We were very aware that there are some of our normally face-to-face delivered courses that at some stages tackle some fairly complex and sensitive topics. So for instance, one of our most popular courses is 6 weeks. On the 3rd week, we tackle issues like early warning signs and triggers. Now, it's easy to read somebody in a room in a conversation. However, you don't necessarily want to tackle that in a virtual situation where you can't be there, you can't provide the same level of support. So our quality assurance panel, which consists of the service manager, a peer trainer, and a lead trainer, would sit down and look at the key topics that needed to be split out, either removed altogether from being virtual, or just focused as an individual topic. So we do maybe a 45-minute or a 1-hour session just on that topic. And what's resulted is basically a production line of courses that have been created, and that's continuing as we speak.
Now, comfort levels with IT. That was a big
Huge.
hurdle,
Yeah.
but something that we overcame, and it was successful. So a lot of staff initially were very reticent to show themselves on video or on a webinar. So it was that one-to-one support that I had to offer them and say, you know what, we'll do trial runs. You and I will meet on webinars and on Zoom or Teams, and we'll have a conversation. The other thing was students, supporting students through the webinars was also important for us. So I would spend anywhere between 5 minutes to 45 minutes just supporting the students so they could attend a webinar.
I think it's that one-to-one support that we were able to provide, whether it's staff or students, that actually broke the barriers of IT comfort that we had. And the last challenge we had, which I think a lot of non-clinical teams will be to get engagement from the clinical teams. And you throw in a pandemic into the mix, and it makes it twice as hard. So we just had to get incredibly smart about how we got our message out, and we used every channel we possibly could. So if we can go to the final slide. What we're facing now, our current situation, is a genuinely blended service. So we've had classroom courses have resumed. We've managed to do about 6 months worth of those. But at the same time, we haven't dropped our online courses or our webinars. We're finding that actually this gives people with a wide geographic range and also who prefer different styles, the ability to access on their own terms any of our content. The hub itself has only been in existence for about 12 months, and in those 12 months it's become the highest ranked page on the Trust website. So I think we're something like 66,000 hits right now, and our students are topping and tailing their learning. So they'll start with the hub, or they'll top up their learning using the hub. So really looking back at it, the pandemic has been a huge boost for us. It's allowed us to move further, faster than we could have done otherwise. And it's a model that I can see as continuing on regardless whether it's pandemic or not.
Thank you both very much. And thank you and the whole team, because this is fantastic. 66,000 hits, and it sounds like you've really increased your reach.
Yes. So right now we have students accessing our courses or attending our courses internationally as well. So we have carers courses that carers attend. Some of them are attending from Germany, some attend from Sri Lanka. And so there are students from Scotland as well. So we are very happy with what we've achieved.
And the age range
And
as
the
well has
age,
been
yes.
interesting.
That's absolutely brilliant. Now there is a question in the chat about digital poverty. You mentioned a little bit about that. Do you want to talk a bit more?
Sorry, what was the question?
About how you dealt with things around digital poverty for trainees, etc. You said you were dropping some.
Yeah, there is a limit that we could do as a team.
Yeah.
The main thing was to make sure that we gave people personal guidance. So in some instances, it would be a case of helping them work through who within their support structure may have IT access that they could tap into. And Andrea spent a heck of a lot of time just doing that one-to-one support. So going far back as helping somebody set up a free email account so that they could actually get the links in order to log in. So just breaking it down as much as we possibly could, but obviously we are restricted to as much as we can do.
Superb. And actually, we just had a question about accessibility, a couple of questions about accessibility. And also I think that our own live captions aren't working so well, so I apologize for that. How did you manage accessibility issues for people where I know you're a big centre for, you do a lot of mental health, you're the National Centre for Mental Health for the Deaf, for example. How did you create adaptations to support accessibility?
So with regards to accessibility for the webinars, we dropped accessibility criteria for the webinars. We wanted to reach out to as many people as we possibly could, and we didn't want to be restrictive. So we just said anybody who wants to access webinars can access them. So we changed the way we managed it on our booking system, and we also put in a lot of manual systems, Excel sheets that we used. So everything was down on Excel. From the first webinar we had was on the 20th of May 2020. And we are having one webinar tomorrow. So,
But I think they're
Yeah.
talking about addressing people who maybe need signer or an interpreter.
Yeah, so that it's both good to hear about both, actually.
Yeah,
But yes,
but
Abby.
on the accessibility side, most of our online course content is either in written form, or if it's audio, it's also got subtitles. That's where we've been able to do it. I mean, we're talking about a very small team who are, some of us, technologically challenged, have done our absolute best with what we've got. But in terms of the interactive stuff that's online, there is absolutely no restriction with somebody having an interpreter with them, or using a sign language interpreter live in a class. We wouldn't count them necessarily as a participant within the class. They could sit with that student. That's not an issue at all. We just explain to the rest of the students how we're going to handle the situation.
We have to move on to the next person. There is a nice question that in the Q&A section about whether there's scope for a national hub in terms of pooled experience, addressing stigma, etc., or does it work better on a local basis? I think that might be something we need to think about, but certainly it's a really good question. And I do need to move on to the Oxleas people, but perhaps we might come back to that you might think about it, we might come back to it in the Q&A section at the end. So thank you all, thank you very much. That's a superb presentation, thank you. And need to move on now. Just to, if there's any more questions, to just put some of those into the chat box as well. If there's particular questions for a particular speaker, to put them into the Q&A, so it's easier for me to see them, because there's much fewer things written in the Q&A, and I'm more likely to pick them out. But it is fantastic to see everybody contributing to the chat box, and so I really wanted to keep doing that too. So it's super to have you all engaged. I see that some people are struggling with sound. I think there are some problems going around with the Wi-Fi. As I said, I have my own. My sound has seemed so far being okay, but I apologize if you are having difficulties. The next presentation is from Oxleas, and talking about the patient experience of remote consultations during the pandemic, and giving us a bit of an update on that. And we have two people presenting: Aisha Abdullah, who's the Senior Patient Experience Officer in Oxleas, and Dr. James Woolard, who's the Clinical Chief Clinical Information Officer and Consultant Psychiatrist. So welcome, James. And is Aisha with you?
Unfortunately, she's not. So I'm speaking her words on her behalf. So
very good.
You know, this is definitely her work more than my work in that case. So very much kudos to her.
Give her our best and our many thanks. And I'm looking forward to hearing your talk.
Thanks, Fiona. Thanks, Fiona. And I guess I think I did one of these webinars almost a year ago. So it's really a timely opportunity to come back and just kind of reflect where we've got to. I think inevitably life isn't straightforward, and where you hope to get to isn't always where you get to in the end. So I think that's a reflection. Things change and you have to kind of respond to them. So as Fiona says, I'm the Chief Clinical Information Officer at Oxleas. So I'm the doctor, if you like, the medic in leading on the digital charge, along with my colleague Nicola, who's on the call as well, who's an awesome digital pioneer and navigator who I really enjoy working with. So I'm glad Nicola's able to share the work that we've been doing as well. So George, if I can have my first slide. So just taking us back to before the pandemic, very much Oxleas, was providing face-to-face, you might call it analog care, if you like. It was based on synchronous people being in the same place at the same time, having a conversation face-to-face. And that's pretty much common across the entirety of mental health. I think it was the accepted practice in many ways. Although I might say remote consultations and video consultations have been tried in mental health since 1950s, when they came up with a television studio. So the psychiatrist would sit in a television studio and the patient would be in another television studio, and they do it that way, which is incredible. I can't imagine that. But anyway, Dr. Hillary or something on Good Morning. So we then saw a shift, and this data is looking at that early bit of the pandemic, where we saw a shift to much more balanced roles around remote consultation and face-to-face. And obviously we shifted a lot to telephone right at the beginning of the pandemic, with a little bit of video. And I think what's interesting, I've got some data later on, is just to show how that's changed overall. So what we took the opportunity to do when we saw this shift is to start collecting patient experience data about, what were patients experiencing when they were having these remote consultations. So can I have my next slide, please? Thank you. So we undertook a survey using a smart survey tool, where it sends a text message to the patient after they've had an appointment, and we send out 35,900 of these surveys between March 2020 and July 2020, and we sent out numbers of kind of prompts and reminders to try and encourage people to feedback. We also asked our clinicians to try and remind people to do the feedback. We also had a non-electronic version of the survey for people in adult mental health services, older adult mental health services and adult learning disability services. And I'll come back to those two groups in a minute. So we sent out huge numbers in survey. What response did we get back? Next slide, please, George. Yeah, that way. Thank you. Okay, so we got 5,000 responses. A majority of them were from actually our children's services, and 2,000 responses from our children's services, 1,500 from our adult mental health services, and then some from our 1,500 from our community mental health services. So this isn't just mental health patients, this is people who've experienced both our mental health and community services. And largely we got a positive response from those, in terms of, 77% of patients felt that they were, better for me or okay compared with face-to-face. We got a positive response in terms of people's experiences, and in terms of people were quite happy to think about using video calls in the future. Now, this was back in July, of 2020. Actually, we've still really been in the pandemic, if we're honest, and it still feels like that very much now with Omicron kind of coming around. So actually, it's one of the areas that we're kind of interested in is that question of, would you be happy to have a video consultation in future? Because actually some people didn't probably get much of a choice because the pandemic continued, and that's a key challenge. So if I can have my next slide. Thanks, George. So some of the themes of the experience, the qualitative themes that came out of that were whether people were happy to have a video or remote consultation was really dependent on the problem. They could understand that for some problems it might be helpful, and for other problems it might not be so helpful. If you want to examine somebody, and the question before about why a physical health service has not used this as much, why have an optometrist not used video consultations as much, or ophthalmologists even, because they have to get close to people's eyes, and you can't really do that via video, although there are some really cool bits of technology that you can attach to your mobile phone. So people felt like they were getting a similar level of care compared with face-to-face, so that was quite helpful. Convenient, some people, especially parents, like the idea that they didn't have to travel to their appointment and take their kid out of school, so take their child out of school, so that was really helpful. But there was a preference for face-to-face appointments to start off with. Next slide, please, George. Fiona, have I only got a minute left or so? Okay, so I'll very, very quick. So basically what's happened over the next year is that we've actually seen a peak in January of our number of video consultations, and then it's dipped back down again. I suspect as you can see on this graph, the blue line, the number of face-to-face has gone back up. So that green line at the bottom is video. Move on to the next slide. This just shows the Attend Anywhere data, which our video consultation platform shows that it peaks and then falls off again. So next slide, please. But what we're not seeing is the same. Am I run out of time?
No, you're not. You're all right. You're fine.
Okay.
I'll just eat into your question time slightly. You carry on.
I just want to I'll be as quick as I want, because what's important is, so some services are still doing video. IAPT services are really doing video, and you can see that in the relatively flat data in IAPT. but actually CYP, who were doing really well at video, you've seen that drop off as well. So next slide, please. So what we're doing next is we're going to do another survey right now. We're designing it right now. We're going to try and work out how we get better representation from older adults and those with learning disability. We saw an underrepresentation of that in our survey data, trying to get a better experience of people's comparison with face-to-face and remote data. Do they feel one is better than the other, especially around follow-up appointments? There was a clear indication that they might have preferred a choice around follow-up appointments. And then it basically giving them an opportunity to tell us, are we doing better at remote consultations now than we were a year ago when you had one the last time? Next slide, please. And future considerations. There is never a right time to do a staff survey. I have been putting off doing our staff survey for about a year because there's always been a reason not to do it, but we are definitely going to do a staff survey looking at confidence, competence, business as usual choice, meaningful choice. Can we offer that? And what are the clinical safety considerations? Understanding the different responses from different communities, and also thinking about some skills development for our digital staff. And I think, Fiona, that might be it.
That is fantastic. A lovely summary, because it's really nice to get an update. And I think the questions you raised of, are we managing it better? And you know, that's really useful. And we've had a comment in the chat about we're dying to hear the next phase, hear more about communication platforms for older adults and those with learning disabilities. We had one question about managing IT failure if there's a truncated consultation. That mightn't show in the data you presented there, but it might, you know, I don't know if you pick it up amongst your survey data, your post-consultation survey data. I might have frozen.
I don't know if I'm.
One of us is frozen, James. I'm not sure if it's you or me.
It's not you, Fiona.
Okay. Well, we will say thank you to James when his internet connection turns on again. I think it is a bit patchy around here at the moment, and say that's great work from Oxley's and really exciting to hear about. Our next speaker is also from Oxley's, and it's Nicola Reynolds, who's the Deputy Clinical Director and principal clinical psychologist in Oxley's. She's for the independent neurodevelopmental disorders, independent neurodevelopmental service. And she's going to talk to us about a remote support project for the families of children with ADHD. So I'm really looking forward to hearing about this, Nicola. Thank you for coming to share with us.
Thank you, Fiona, and good afternoon, everybody. Yeah, so as Fiona just said, I work in Oxley's, and I am the clinical lead for the integrated neurodevelopmental team. So that's the team that provides support to children who present with ADHD and autism spectrum disorders. But I'm going to be focusing on the ADHD team today. So as James mentioned, we work together in that team, and he's the consultant psychiatrist in that team. And I'm going to be talking about the sort of support that we've tried to provide to parents of children with ADHD, sort of during the lockdown and since. Next slide, please, George. So the ADHD team sees children that are aged sort of 5 to 18 who have a Greenwich GP. Our remit is to provide sort of diagnostic assessments, but also ongoing management, which you know, is often medication, but also providing sort of behavioural support to parents. And the NICE guidelines say that, you know, following a diagnosis, families should be given information about ADHD and given some sort of specific ADHD support and behavioural advice. And that can be delivered sort of individually or as a group, and it can be as few as sort of 1 to 2 sessions. So prior to the pandemic, we had always offered a group session to families following a diagnosis, which was face-to-face. When the lockdown happened, we were, you know, really mindful of the fact that our parents were going to be under particular, you know, high levels of stress, and we know caring for a child with ADHD is particularly stressful anyway. But when that child is at home all day, every day, because they can't go to school, and parents were trying to juggle working, you know, it was a stressful time for everybody, but we knew it was going to be particularly stressful for our families, and we wanted to think about how we could provide support to them during that time. So next slide, please, George. So one of the things that we did was to develop some sort of presentations on topics that we knew came up quite often with our families. So things like what is ADHD? Just some psychoeducation for those families that were fairly recently got a diagnosis, and also some sort of strategies around how to manage ADHD. So some of those sorts of reasonable adjustments that we would typically recommend. We also developed some presentations on things like positive parenting and positive behaviour support, and strategies to help children sort of regulate their emotions. So we know that those are the things that parents regularly come to us about for advice, and the particular areas that they sort of struggle with. And then we also did a video on sort of medication and some of the sort of options of medication, some of the sort of pros and cons and the side effects and so on. So these were the sorts of topics that we would have covered in the face-to-face parent information session. So we've developed them as sort of PowerPoint presentations, and then our member of the team is sort of talking over those presentations. And we created our own sort of private YouTube channel and then uploaded these videos to our own channel. So they're not sort of publicly available. And we then share those links with parents when they've had their diagnosis. We would send the report out, and these links would be included in that report so that they can access that in their own time. It can be during the night if they want to. They can come back to it and dip in and out. So the information is always sort of there for them. And alongside this, we also offered the parent group remotely, so via MS Teams. That's offered as a group session, and we sort of go through the sorts of material that we would have gone through in the face-to-face session, generally covering these sorts of topics, but perhaps not quite in the same level of depth. The parents had the opportunity to ask questions in that session, and then the slides are emailed to them. And about 2 weeks after that group session, there's a follow-up telephone call, so that parents have a bit more of an individual opportunity to ask any questions about things that came out of the parent session, once they've had time to sort of absorb and digest the information that's given to them. Next slide, please. So what we found is that delivering the group session remotely has actually been really successful. We've had very few parents that have said that they can't access it. I mean, just thinking about in the last year, there was really only 4 parents that just said they just could not access it. And so for those parents, we did do a face-to-face session for them, obviously with social distancing and masks and so on. But on the whole, parents have been able to access it fairly easily. And we've been able to sort of extend the offer to more parents. It's been more accessible, because one of the things that we were always constrained by previously was room availability. So the clinic where we work has only one large room available for running groups. And there are a number of teams that share that building, and so that room is often in quite high demand because lots of services like run therapy groups and parent groups and things. So we were often restricted a bit to how regularly we could offer that session, and we could only have sort of 6 parents really at a maximum in the room, and that was even sort of before the pandemic. But now we're not constrained by that. We can sort of run the group, whenever there's a clinician available to run it. It doesn't matter whether there's a room available or not. But we can also have more parents on the call than we would face to face. So we now have around 15 parents in the groups when we're doing it remotely. So more parents are being able to access that group more easily and not having to wait so long. Because often the delays in finding a room and having the restriction on numbers, it meant that some parents had to wait quite a long time before they were offered that parent group following a diagnosis. So they often felt that they've got the diagnosis and then been left for quite a period of time with nothing. whereas now we can offer that group to them, much more sort of quickly after their diagnosis. We've found that the DNA rate is pretty similar, really, looking at the DNA rate we used to get when we did it face-to-face. It's not really different. Lots of parents have said that they actually find it easier because they don't have to travel, they don't have to worry about childcare if they've got other children at home. And as I say, if we need to, we are still offering it face-to-face, but we just genuinely haven't needed to because parents have been able to access it. I mean, what we did do last year as well, sort of in terms of thinking about sort of digital exclusion, was we developed a questionnaire for families that asked about their confidence in using digital technology, but also what they had access to, whether they had devices at home, whether they had access to sort of secure, stable Wi-Fi. And we send that questionnaire out now to families right at the point of referral so that we can be identifying families right at the beginning of the care pathway who may not be able to access a service remotely, and then we can sort of ensure that they do get that sort of face-to-face option. The feedback that we've had from families in the follow-up phone call has been really, really positive. So families have all said that they found it really, really helpful. We haven't asked specifically about feedback about the YouTube videos, and I think that's probably something we do need to think about doing. And when we've looked, the number of hits on those YouTube videos are quite low. So I think there might be a bit more work we need to do as a team to think about why that is and whether we need to kind of promote them more widely. But certainly the online session has been really, really well received. So for us, I think that is something we will going forward, we'll sort of continue to offer remotely. And I think that's it from me. Very quick presentation.
Nicola, that's fantastic body work. Thank you for presenting it so well. That's really interesting to hear. Got a couple of very quick questions before we wrap up for the day. And one quick question: did you make ADHD diagnoses through remote assessments as well as doing follow-up and support?
Yes, we did. So before we see children for an ADHD assessment, we send out lots of pre-assessment questionnaires like the Conners and the school questionnaires, but we also use the QB test, and that is done face-to-face in clinic because it could only be delivered face-to-face. But the follow-up bit where we're reviewing all of the information is done remotely. And we often found that was actually quite helpful as well, because you could sort of observe the child in their home environment when they've got their usual distractions around them. Because we often found in clinic when children came in for their ADHD assessment, they could often manage themselves quite well for that sort of period of time. So we've found doing the assessments, a sort of blend of face-to-face and remote quite helpful.
Worked well. Nicola, that's really, really helpful. Thank you very much, and well done to you and your team on all the work you've done there. We have had quite a number of questions in the Q&A and the chat, but we are running out of time. But somebody made a good point about sharing the chat, because actually people have been sharing ideas about non-trackable websites, etc., and also nice conversation about Shauna Duggan, you were saying about phone booths for people to come and use as a pod-like thing in Northern Ireland, and that's apparently available in Wandsworth as well. People are sharing practices on that. So I don't know whether we might be able to pull something together from the HIN team afterwards to be able to pick out some of this. But it's really, really helpful. Thank you very much. And to thank all of the presenters and the audience for coming, fantastic presentations and a fantastically interactive audience. Thank you so much. It is important for us to learn from you. Because of course we've all been doing the same thing. We just, are all beside each other, and we're very lucky to have the HIN to support us to work together to pull this information together. But it certainly is only a fraction of the information that everybody around the country is developing. So the more we can learn from you, the better. And thank you so much. And there is a find out more slide with a link to the triangulation report and the web page and the resource page where we've literally put everything that we've pulled together onto the HIN web page. And Linda, you're going to put you've put a link to the case studies in the chat there for that. There is a poll on the screen about how useful you found it, and I'd really encourage you to fill that out, because it would help us for the future. And Thank you very much. I think we should be finishing now, and to let you have a few minutes before your possible next meeting, which may or may not be on a remote system at 2 p.m. And really appreciate you coming. Thank you so much, and thank you for the presenters, and thank you to the HIN team for hosting and putting this on, and to Q for funding and supporting. Thank you.